Hello guys, today's topic is actually two, endometriosis and adenomyosis. And let's clarify the questions that dismissed, or maybe confused you, misunderstood during previous state exams, board exams. So take your pens, papers, and let's clarify the points. Okay. Let's go. So, endometriosis and adenomyosis are two distinct but related estrogen-dependent gynecological conditions characterized by the presence of endometrial-like tissue outside endometriosis and within endomyosis and uterine muscle. So, endometriosis is defined by the presence of endometrial-like glands and stroma outside the uterine cavity. These implants can occur anywhere, most commonly in the pelvis, ovaries, peritoneum, uterus, sacral ligaments, but rarely even in distant sites like the lungs or brain. What's the clinical issue of that? This ectopic tissue responds to cyclical hormonal changes leading to inflammation, bleeding, scarring, and adhesion formation. This explains the classical triad of dysmenorrhea: painful periods, dyspareunia. Dyspareunia is a painful intercourse, dysmenorrhea is a painful periods, and chronic pelvic pain, as well as potential infertility. Recognizing this pain isn't just a bad periods, but a pathological process is a key. Adenomyosis involves the presence of endometrial glands and stroma within the myometrium, the muscular wall of the uterus, at least 2.5 deep to the endometrial-myometrial junction. This leads to a diffusely enlarged, often boggy and tender uterus. Boggy and tender uterus. So clinical issue of that. This invasion causes uterine hypertrophy and dysfunction. Classic symptoms include menorrhagia, heavy menstrual bleeding, and severe dysmenorrhea, painful periods. It often coexists with fibroids, making diagnosis challenging. Unlike endometriosis, which is outside the uterus, adenomyosis is a disease of the uterine wall itself. Okay? Endometriosis and adenomyosis frequently coexist in the same patient. Estimates range from 40 up to 80% in some studies of women with both. Their symptoms can significantly overlap, making distinct diagnosis difficult based on symptoms alone. When one condition is diagnosed, a high index of suspicion for the other is warranted, especially if symptoms persist despite targeted treatment for the primary diagnosis. So this requires a thorough evaluation, often involving advanced imaging. For example, a patient with diagnosed endometriosis and persistent menorrhagia, heavy menstrual bleeding, despite endometriosis treatment, might have underlying adenomyosis. Endometriosis is increasingly recognized as a systemic disease involving chronic inflammation, immune dysfunction, and neuroangiogenesis, so new nerve and blood vessel formation. It's not just localized pelvic pain. Clinical issue of that. So this explains extrapelvic symptoms like fatigue, bowel and bladder dysfunction, often cyclical. For example, painful defecation or urination during menses, and even mood disorders. Treatment should be holistic, addressing the wide-ranging impact in quality of life. Get it? The gold standard for diagnosing endometriosis remains direct visualization and histological confirmation via laparoscopy. For adenomyosis, high-quality transvaginal ultrasound and magnetic resonance imaging, MRI, are key non-invasive tools with definitive diagnosis often post-hysterectomy. The average diagnostic delay for endometriosis can be 7-10 years from symptom onset. Delay. 7-10 years from symptom onset. So clinical importance of this, the high index of suspicion is crucial. Transvaginal ultrasound can show endometriomas, chocolate cysts, or signs of deep infiltrating endometriosis. For adenomyosis, look for transvaginal ultrasound signs like a globular uterus, myometrial cysts, heterogeneous myometrial ecotexture, or the question mark sign. MRI is excellent for mapping deep endometriosis and confirming adenomyosis junctional, though thickening more than 12 millimeters. Validate patient symptoms even if initial basic imaging is normal. Actually, both conditions, endometriosis and adenomyosis, are significantly associated with infertility. Endometriosis can cause adhesions distorting pelvic anatomy, affect ovarian reserve, especially with endometriomas or surgery, impair oocyte quality, and create an inflammatory pelvic environment hostile to sperm and embryos. Adenomyosis can impair implantation and increase miscarriage rates due to altered uterine contractility and hostile endometrial environment. So what's the clinical issue of that? These conditions must be considered in the workup of infertility. Treatment strategies for women desiring fertility differ significantly. For example, conservative surgery for endometriosis, medical management to optimize uterine environment for adenomyosis or proceeding some assisting reproductive technologies, and so on. For endometriosis, the stage of disease based on surgical findings, like ACRM classification, AS, American Society for Reproductive Medicine. So for endometriosis, the stage of disease doesn't always correlate with the severity of pain symptoms. A patient with minimal stage 1, disease can have debilitating pain with while another patient with extensive pain, stage 4, disease might have fewer symptoms. What's the clinical issue of that? Treat the patient's symptoms, not just surgical stage. Pain in the endometriosis is complex, involving inflammation, nerve infiltration, and central sensitization. A multidisciplinary approach to pain management is often required. While rate, 1 up to 5% maximum, less than 5 of course. So less than 5% of cases, endometrial implants can occur in almost any organ system. We talk about endometriosis, including leg diaphragm, causing catamenial shoulder pain or even pneumothorax, gastrointestinal tract, causing cycle bleeding or obstruction, urinary tract, surgical scars, and even the brain. So why it's so important? Consider endometriosis in differential diagnosis of cyclical symptoms related to other organ systems, especially in women with non-pelvic endometriosis or unexplained cyclical phenomena. This requires a high degree of clinical acumen and often specialist referral. So actually about cyclical symptoms, don't forget about familial Mediterranean fever as well. Okay. So we have to understand that there is no single cure for either condition, endometriosis and adenomyosis, especially endometriosis. Management is aimed to symptom relief, improving quality of life, preserving, restoring fertility, and preventing recurrence. Options range from analgesics like NSAIDs, non-steroid anti-inflammatory drugs, hormonal therapies, so combined oral contraceptives, progestins, gonadotropin-releasing hormone agonists, antagonists, to surgical interventions, excision of endometrial lesions and hysterectomy, unfortunately. So, why it's so important? Treatment must be individualized based on symptom severity, patient age, fertility desires, previous treatments, and potential side effects. For adenomyosis, hysterectomy is curative, so-called curative by other options, but other options like hormonal intrauterine systems device, IUS, for example, levonorgestrel releasing IUS or uterine artery embolization exist. Of course, shared decision making is paramount, of course. So if you will be asked about my beloved's etiology, I don't think in pathogenesis, I don't think you will be asked about that, but anyway, we have to understand that exact pathogenesis of both conditions is still not fully understood at all. Though theories, no speculations, for endometriosis include retrograde menstruation, coelomic metaplasia, stem cell origin, what else? And lymphatic vascular spread. Genetic, epigenetic, and immunological factors are heavily implicated in both, but all these are all just speculations. But anyway, if you will ask, who knows? You answer in this manner. Genetic, epigenetic, and immunological factors. Ongoing research aims to identify non-invasive biomarkers for earlier diagnosis, develop more targeted and non-hormonal therapies with fewer side effects, and ultimately understand the root causes to potentially prevent these conditions. Well, that's enough. That's it, huh? That's it, yeah. That's all that I want to clarify. The misunderstood questions confuse you. These several years previous past state board exams. Be in touch. Don't forget to follow and subscribe my Dr. Y YouTube channel. As well as don't forget to follow and subscribe my Telegram channel. It's a private channel in Telegram, Dr. Y, in Telegram channel. So how to find this Dr. Y? Easy peasy. You type in searching mode Dr. Y, W-H-Y, Dr. W-H-Y, like question, without question mark. Dr. W-H-Y, it's me. You click start and choose your plan. God bless you.